Chaplin. I'm going to give a short presentation on autism and mental health. Just by way of starting, it's just really going to be an overview and really some approaches to evidence-based assessment and how central psychiatric disorder may present in different people. From the discussion we've just had, there is nothing I've found really on BAME communities on mental health, apart from perhaps young black youths being overdiagnosed, perhaps with schizophrenia sometimes, or behaviour being mistaken for other stuff, a lack of definition. Studies I've found from databases looking at these things say there's no real significant difference, but you're looking there from a starting point where BAME individuals are less likely to get a diagnosis anyway of autism. So I think we need to go quite a few steps back to make sure that any information we do get is reliable kind of for in the future. So most of the studies then you'll see a kind of generic, whether they're kind of clinic-based population, general populations, but no groups kind of stands out. In the early days, fears of autism were previously associated with schizophrenia. Lerner 1911 brings that out, equals 4A's. And also, he was influenced by Freud, and so we've got kind of psychoanalytical styles for reasoning. Up until the 60s, we have no kind of real agreement on definition. In the 40s, we kind of had the Kanner study and then Asperger, and then we have various people seeing what autism really is. And all of this discussion at this time is done under the context of kind of psychiatric disorder. It's not until the 70s that we kind of move away from that and see autism as a developmental disorder and not a mental illness. Because still, up to that time, they're looking at hallucinations, trying to put that as part of the category. And by the kind of early 70s, that's removed and we can start to concentrate, particularly in children, that it's a developmental disorder and it's all right. A mental illness is something totally separate. But what you'll get is kind of hangovers from history in the past, is that sometimes people still can't differentiate that. So you still get, like, some people maybe talking from a point of ignorance. All the literature seems to suggest that autistic people are increased risk of developing mental health conditions, and they get substantially higher rates than the non-autistic population. Prevalence is a wide range, 16 to 35%. But remember, that's a number of different disorders, so there's nothing really that's telling us, but it's quite a significant number that are either having mental health problems or mental illness. What we see when we look at autistic people within clinic populations, we see much higher rates. And that we can hypothesise really just because the people who are actually going to clinics have some support needs anyway, or going for some assistance, and that's why we see the elevated rates. And this is something to look at when you're looking at prevalence as well of mental disorder, that where the location is, because certain locations, by virtue of what they are, will have high rates of mental health problems. So why the increased risk? We know as well there's increased physical comorbidity, medical conditions such as epilepsy, genetic conditions, Fragile X, also neurodevelopmental disorders, other ones, ADHD, intellectual disability. Also, we've talked about, or someone was talking about the mortality review, early mortality. So, as well, there's more complex. And what this really shows us is that some syndromes may give us more understanding, do have higher rates of mental health problems, some syndromes that may be associated with autism as well. So, an example, Down syndrome, higher risk of depression, roughly is estimated around 10% of children with autism also have Down syndrome. Fragile X, higher rates of anxiety and depression in the average population. And there's other disorders as well, which are.
So I just put in that I saw like that study on like his head now.
Yeah.
But before we have like high vitamin B12 from atypical and the doctor say like, you know, that's kind of common for autistic people, but I don't understand why. Like, what at this point I'm telling
I'd have to kind of have a look to give you a proper answer, to be honest with you. I don't usually.
but do you ever hear about that?
There's different stuff of kind of vitamins, but I don't know. Anyone else in the room, any kind of evidence about this? Usually haven't heard nothing kind of research-wise really on it, but I'll have a look, see if I can find out in the break, see if there's any evidence around it. It's not something that I've come across or something that's mentioned quite a lot in the literature. So other conditions may be valiocardio-facial syndrome, which also has a high incidence of schizophrenia, and other disorders such as that. People with intellectual disability, higher risk of experiencing psychiatric disorders, kind of depression and anxiety, there's kind of varying votes, not much difference, but slightly higher. But things like schizophrenia as well, which is also associated with 3% of the general population, 3% of the intellectual disability population, when it's only 1% within the normal population. So there's certain disorders, if you have intellectual disability, you're going to be at much higher risk. But what we know in the context of autism, we're not quite sure what role IQ plays within this. So there's some studies to say that a higher IQ is not a risk factor, but then again, there's other studies in high-functioning children to show that they have high rates of depression. So we need kind of more reliable, more population-based studies to look at that. ADHD. This one is interesting because if you had autism, you could be diagnosed with having ADHD at one point. And this is because kind of symptom overlap. They reckon symptoms common in people with ADHD and autistic people, there's a prevalence of kind of 30-50% kind of overlap of symptoms. If you put other neurodevelopmental issues in there, such as learning difficulties, genetic syndrome, it goes up to 83%. So you see this very high crossover. But what we see is there is some symptom overlap. There's one here, perhaps switching attention, sustained focus, keeping attention because people are kind of buzzing around. But what happens is usually symptoms of quality, they present slightly differently in different disorders. So someone not paying attention in one disorder, such as ADHD, may be because they just can't sit down. Someone, an autistic person, it may be because the activity, they just don't like it, or they've been asked to do something. So what you can see if you're doing a tick list, everyone's got everything, but you have to kind of go and have a look at the symptom profile and what's actually behind it, and is this normal behaviour for the individual, or is this out of character? Up to the bottom, ADHD again, higher risk of things. In terms of assessment, what we find is atypical presentation within the general population in some areas. That's not to say that all autistic people present atypically, that's not the case. But what we've got is, we've got autistic people who are very different, and we've got people, say, who are depressed, who are also very different. And when you put all those different combinations together, only certain things will apply to certain people. But what we do know is what we don't know is that there's little known about the etiology, prognosis of mental health problems in the context of autism. If we say that, we don't know a great deal in the general population, but we're more able to predict what's going to happen and what the kind of course of an illness will be. Also, carrying out assessment and making a valid diagnosis are considerable challenges, and diagnostic overshadowing being a well-known complication. This is where somebody may present and who's kind of in distress, and the person will say, well, that's because they're autistic. It won't be that their behaviour is different, it's because that usually the person assessing hasn't the experience of autistic persons, how they behave, and not kind of realising that usually when people do come to seek help, they're very different than they are usually. And a lot of the time people will take that as what the person's like normally, and it won't get very far. Also, the eligibility criteria to get into mental health services is very high. You've got to kind of have severe mental enduring illnesses. What usually happens, or what can happen with this group of people, is that things might start off relatively low level, but without a lack of support, these issues increase for them. And what happens is usually then people will get into trouble, and it'll be a kind of, the experience will be a far more, or will be a worse one, will be usually secure environments, or they may be picked up by police. And that's just because of a lack of support and understanding at the lower level. And that really starts at primary care, GP level, not within your hospital. What we also find is when somebody becomes mentally unwell, that the actual traits, or the person's traits every day, become much more pronounced usually. And this psychological physical stress, it's very difficult to kind of put these out, what the kind of core symptoms and what the symptoms of mental illness are. Also, we're getting other features of autism may overlap with symptoms of a range of mental health disorders, making it for them to identify what they're experiencing disorders. What this means really is that sometimes people don't realise the significance of their experience. So people may present all right and they'll look at sleep, but they don't realise that, well, I don't usually not sleep for 5 days, it's been okay because they may have been occupying themselves. So to them it's not an issue. But there's these kind of subtle biological changes that people might not kind of recognise or realise like other people might do. This is about diagnosing. The first bit is the DCLD and DMID2, and these are for diagnosing mental illness in people with intellectual disability. And that's usually in people on the severe range. It's people who have difficulty communicating, expressing their symptoms, etc. This is about diagnosing. The first bit is the DCLD and DMID2, and these are for diagnosing mental illness in people with intellectual disability. And that's usually in people on the severe range. It's people who have difficulty communicating, expressing their symptoms, etc. The normal criteria, or everyday criteria, ICD-10 or DSM-5, it's usually used in people with intellectual disability if it's mild than the rest of the population. But in terms of autism, we've got no evidence really on their utility on how people really with autism present. So, whereas with ID we have these diagnostic criteria to show how symptoms may present atypically, in autism we have no such thing at the moment. So nobody kind of says that you might be looking at this person and they may present like this rather than this, or they not be able to communicate. There's nothing to guide. So the nearest we have to any adjustment made was with the intellectual disability population. And also, people can't agree whether these symptom definitions should be modified in the first place. Does it make it easier, or are you measuring something else, which is the big area of debate. Now, this is part of the clinical assessment, setting the scene, and really a lot of this is just good practice for anyone. And I think this is like what we should aspire to when we're developing services. And it's really considerations during the assessment, using clear language, ensuring people understand what they're expected to do, keep the interview to a reasonable level, not tiring the person. The clinic environment should be calm, acknowledging these sensory difficulties. But we know that most GP surgeries at places aren't really like this, and so we have to put guidelines. And, you know, everyone would like a bit of this, with a little bit extra for people who find it extra difficult, even if in a quiet kind of low sensory environment. Also, be patient. It takes several meetings to present. So, in terms of communication, sometimes there's difficulty describing in the world of emotions such as anger, sadness, depression, how people feel. So I kind of alluded to earlier, sometimes some of the early warning signs are biological. It may be lack of sleep, changes to eating. It may be something there that you can kind of look more at these issues. Also, there's the one, reduced communication skills, maybe in certain settings. There may be literal interpretation from people. And the subtle and complex presentation over time, mental health problems such as psychotic symptoms, depression system, requires time with that person and understanding from the people that know them well.